Hello everyone, welcome to the clinical case outcome from this week. This Monday we presented the 3-year-old female spay Maltese Terrier with 2-week history of intermittent yelping and 2-day progressive history of non-ambulatory tetraparesis, had normal spinal reflexes on all 4, normal cranial nerve evaluation, normal mental status and cervical hyperesthesia. So what is the neurolocalization? The neurolocalization based on those neurological deficits will be explained by a C1-C5 myelopathy. If we have to consider the differential diagnosis using the clinical reasoning, so we have this 3-year-old female spayed Maltese Terrier with chronic, progressive, non-lateralized, painful C1-C5 myelopathy. Etiological diagnosis will involve inflammatory infectious and neoplasia and also degenerative process with, for instance, a degenerative intervertebral disc extrusion. The dog underwent hematology and comprehensive biochemistry that did not reveal any abnormalities. Also, Neospora caninum titers were also negative. It went for MRI of the cervical spine, and after these findings, we also included the MRI of the brain. If you haven't done it yet, I strongly recommend that you listen the MRI explanation by Fraser that were uploaded on Wednesday. And the MRI differentials based on those MRI findings were meningoencephalomyelitis, immunomediated or infectious in origin, or neoplasia, mainly including lymphoma or other round cell tumors. So, what we did from there, the dog underwent CSF, and based on the MRI description and based on the malformation at the level of the atlanto-occipital joint, the CSF was performed lumbar, and the CSF showed severe lymphocytic pleocytosis with the total nucleated cells 5,280 when it should be less than 7-8 nucleated cells at the level of the lumbar cister, and also increased total protein. So based on the cytology, based on this evaluation of the CSF, the most likely differential diagnosis was a meningoencephalomyelitis, because there were also changes affecting the brainstem and the cerebrum, and also changes affecting the meninges and the spinal cord. Based on the literature, a nice review done by Cornelis that was published in 2019 showed that in the literature there are 15 dogs that were clinically diagnosed with meningomyelitis, and of those CSF was performed in 22, and all of them showed pleocytosis with a variable increase on the total protein value. So when we talk about the outcome and the treatment and outcome on this case, is based on the fact that the exact etiology and pathophysiology remains still unknown, and this is a nice review about this condition I was talking about. We tend to use the standard treatment protocol, which is based with serial injections of cytarabine, arabinose, and prednisolone, and the dog underwent this treatment. This is 4 days after starting the treatment, and there were already improvement. The dog was nearly ambulatory without assistance. Just this was about 7 days after starting the medication, and this is when the dog came for a recheck for the second dose of cytarabine arabinose at 3 weeks, and the dog so far continue on the standard treatment protocol and continue to do very well. So the cornerstone treatment modality for this condition is agreed that is immunosuppressive therapy. However, the protocols are several, and based on the literature, there are different protocols with different long-term outcomes, and based on the different inclusion criteria, they are very difficult to make a conclusion taking into account all the published studies. But what is a common or the cornerstone is that all of them required immunosuppressive therapy. I hope you enjoy the case. If you have any particular question, please let us know. Otherwise, we'll see you next week with another one. Thank you.